Hello, everyone. I hope you all are doing well and surviving the monsoon rainy season there. I remember what that was like when we lived there. We have had some rains and some flooding of the Mississippi River that comes from up north, the river that flows from north to south U.S. But it's starting to recede. And we live up higher levels in Moline, so we've been good, not affected by the flooding river. But anyway, you're in my thoughts and prayers, and I hope your learning is going well and you're applying it in your situations that you counsel and do chaplaincy work at the hospital and other places. Today's topic is how can you assess mental state of someone? How can you assess the mental state of someone? And Chaplain Nato is going to give you the CPE online class materials for August 7th, 2024. And the case is this. History. A 42-year-old woman comes into the hospital for a laparoscopic colon cystectomy. That is the removal of the gallbladder. The admitting doctor has concerns about her mental state. There are concerns about whether she is healthy enough to cope with an operation and the recovery from it. The doctor takes a psychiatric history. Question. In addition to the history, what assessment will give more information about this woman's mental health before a decision is made whether to proceed with the surgery or whether to ask a psychiatrist to see her? So, a physical or a regular MD physician can do a very, very basic um, history of the person's medical history and if there is any psychiatric history, but a formal psychiatric exam would need to be done by a certified psychiatrist. And so the question is, if you were in this situation, what would be an assessment that could give you more information? Well, of course, the answer is the medical state examination, the mental state examination. And interestingly enough, it is equivalent to the physical exam in medicine or surgery, but assessing a different system in a human being's body. It takes place through observation and probing questions designed to elicit or bring about a psychopathology if it is there. So, this mental state exam, is structured and follows a format or procedure, and together with the patient's history and other investigations if needed, they will come up, you can come up with a formulation which is the summary of the mental health, the problems, and their relationship to other aspects of an individual's life. So, I don't know what situations that you will be in that you will be having there where you live and what you are doing. If it is hospital ministry or industrial chaplain or school chaplain or what the situation is. But I know that since you all are not licensed psychotherapist or psychiatrist, then your formality would be different, but we can still be learning how to assess a mental state of someone. And so the information that goes into the formulation, it describes three P's: any predisposing factors, any precipitating factors, and third, any perpetuating factors. So the mental state exam includes one, two, three, four, five, six, 8 areas actually. So we're going to go over those right now. And this might be a lot for you to write down, but I understand that Chaplain Nacho will have this document for you to have individually. The way that you do a mental state exam is a lot through observations and then some probing questions if necessary. So the first one is appearance. And with this case study about the 42-year-old woman that wants to have her gallbladder taken out, you would first start with the woman's appearance. Now, most likely she would already be in the hospital or at the doctor's office. But when you look for an appearance, you look for hygiene, you look for clothing, hair, makeup. Do the clothes suggest any subcultural type of group? Are there any signs of neglect or perfectionism or grandiosity? The way a person dresses can also be an outward sign of what they're thinking inwardly, just very flamboyant, very grandiose. And also in the appearance part, you would look to see if they have any inappropriate appearance or dress, anything that is disheveled about them, or, on the opposite end of the spectrum, are they very, very neat? So this is the physical appearance. And then the behavior. This is observed throughout your interview or discussion or conversation with the individual. And you look at evidence of rapport or connection, empathy. Are movements slow or rapid? Is the person agitated, or is there any psychomotor slowing down, retardation of movement? And each may be a possible signal for disorder. So in a person's behavior, or in this case study, the 42-year-old woman, behavior says a lot about mental state. And so you're looking for any sign, signal of any kind of disorder. For example, sometimes appearance and behavior will be a sign for depression or Parkinson's or autism spectrum disorder, any kind of mania with bipolar, schizophrenia, personality disorder. So does the person sit still or move around, quick movements, eye movements, or are they calm? Are they distractible? impulsive? Are they monitoring or looking around them in their environment constantly? For any, that would be a sign of any mental phobias, something that a person is extremely obsessively fearful of. And so, also obsessive compulsive disorder, and especially with children or teenagers, the looking for the autism spectrum disorder. So, behavior is important, and there's a lot more that we could say about that, but you will learn as you go along with even some of these other categories. For example, speech. Is it normal? Is it impoverished? Do they not talk in thoughts that can be understood? Are they, do they feel stressed or pressured? You can tell that by speech. So you're assessing the volume, the flow of the conversation, the content, the pitch, the tone, and the patterns or rhythms in the sound. A person with mania may be loud, have the flight of ideas, of speech, and using different types of speech. A person with schizophrenia may be totally not understandable if they have formal thought disorder. So if there's this thought and speech disorder connected together with schizophrenia. A person with autism spectrum may have little communication or may speak only on one subject at a time, and they don't like to have eye contact. And then we have in also in behavior is mood. And this you're looking for assessing, is the mood subjective or objective? How does the person describe their mood when you ask them, uh, you know, how are you feeling? How would you say your mood is today? What's the what's going on with you today? And is it congruent with what you see? Whatever they say their mood is it congruent with what they say and what you see in the room, in them, in your experience talking to them? So you can ask them to assess a person's mood. You can ask them questions about what do they enjoy, how do they see their worth, um, are they filled with hope or despair, especially seeking to find out if they might be suicidal or have a risk of suicidal tendencies. So once again, mood is very important. And um, in psychiatry and psychology, there is a term that's called euthymic. Is the mood euthymic? EUTHYMIC. That is the definition of that is a normal, tranquil mental state. So, is the person euthymic, or anxious, or angry, or depressed? Euphoric, which you would find in bipolar when they're manic, irritable. So those are moods that you want to look for. And then in the affect, AFFECT, you're also looking for the affect of a person. There, and it kind of goes along with the mood. Are they flat? Are they, is it full? Are they are you seeing rapid changes quickly during the conversation in mood? So it would be opposite of someone that comes across as stable. And so those are some things: affect, eye contact, speech, appearance. All of those are important observations. And then to assess their mood and then we go into the cognition part of a person, and that is several different categories. There's the memory impairment or attention, how well they focus and are attentive, and perception. And so we're going to talk about a few of those right now. So in the perception, you assess their perceptual experiences by observation and questioning. Is the person responding to the visual hallucinations of delirium tremens or organic brain disorder, or the auditory hallucinations of schizophrenia? So those are two different types of hallucinations, visual and auditory. And a lot of that is from an organic mental health condition or psychotic depression. So I think, in my opinion, a person wouldn't be that far along if they were about to have surgery, that their regular primary care doctor would know that from them coming in for a doctor's office visit. But in extreme situations, there may be a situation that you are involved with that you see those kind of things. And it's how that person is seeing their external world and how they're processing it in their mind, in their brain. So, um, and when a person is on drugs or using alcohol, it perceptions can be very different. They can be dulled. What their perception is of what they think they're seeing and experiencing in a person or a situation can be dulled in that. Um, and then also, we talked some about bereavement last month. There can be some pseudo hallucinations when a person is going through bereavement. They may be thinking in early stages of grief or bereavement that they might believe that they see the loved one, the person that died, or that they um, dream or see visions of that person, waiting for that person to come back home. Those kind of situations, they're important markers of mental illness. Um, Thoughts. A person's thoughts are very powerful. And as we have talked previously about suicide ideation thoughts and depression, well, thoughts that are intrusive thoughts that a person, when you're assessing them and doing some probing and trying to draw them out, asking them about their thoughts. Do they feel suicidal? Have they planned or thought through how they would commit suicide? You're assessing those kind of thought patterns that a person might have. Also, people that are manic, their thoughts race and they do not connect different subjects together. They'll race in one train of thought, then they'll race in another. So, are they negative thoughts? Are they obsessive compulsive? So, those are the kind of thought patterns you're trying to assess when you're doing a mental state status exam. And then also, if a person is homicidal, they can express a lot of anger, aggressiveness, intent, or plan to commit homicide acts. Delusions, sometimes the delusions can be religious, sometimes paranoia, sometimes just this grandiose um, delusion of themselves. And so you've got several things that are in the cognitive area. So perception, how that person perceives their external world and people, their thought patterns for mental health issues or disorders, their behavior. We've talked about behavior. Sometimes, if a person's very guarded or agitated, then that is a signal of something mentally going on with them. Aggressive, bizarre, withdrawn, or maybe they are cooperative. That would be part of your assessment. And then you go into insight, and you want to know what are their attributions. How do they view their problems and their need for treatment? Do they see themselves coping, or do they see themselves not, but they don't want any help? So that would be part of your assessment that you would note, write down, and know as you work with them. And then cognitive function, those would be some of the things that we've talked about already, like depression or, bipolar, schizophrenia, those kind of mental disorders that we have mentioned. So that kind of gives you the lineup of um, assessing a person, and a lot of it's very much observation, and then through your experience and talking with that person and observing them, you're taking mental notes as you're talking with them, observing in these areas, these categories. Then you would write down what you find. If you need to, ask questions that would allow you to find out more information in these categories. And I think that if you need a form to do this, I mean, typically when I see patients in the mental health unit, then I would record my visit with them, but the psychiatrist or psychologist would go into detail in a hospital setting with this mental assessment, and then if needed go on to a more deeper psychiatric exam. So I think Chaplain Nato is going to give you or show you this. This is just a condensed, shortened way to keep this with you, and it goes over the things we've talked about so you can remember, check those off: appearance, behavior, speech, mood, affect, thought process, thought content, suicidal or homicidal, cognition, dementia, insight, and judgment. How that person is making either good judgment or poor judgment about things. So, this is something you can have individually, and MSE stands for Mental Status Exam. So that is all that I have for this didactic. And if you have any questions, as always, please message me, and so that I can see it. I know you have to turn in your reflections to Chaplain Nato, but if there's anything you want to ask me personally that I can help clarify, then you're welcome to do my Facebook Messenger as well. Depending on what's going on in my life, sometimes I follow all of the thread of messages on Messenger, but sometimes I get busy and don't. So, anyway, I think this is helpful if you can follow this uh, graph table and kind of memorize some of that as you're working more and more in your settings for chaplaincy and pastoral care. Okay, thank you. Take good care. See you next time. Bye bye.